Hello. Thank you very much for agreeing to participate and to being the special guest.
All right, thank you very much for inviting me. I appreciate it. What time is it? You're down in Australia, are you not?
Yeah, it's 11 o'clock. We actually have a day off today for a horse race. It's the equivalent of our Kentucky Derby, so or Derby, whatever it's called. It's a public holiday.
Oh, for a horse race, that's great. I like that culture.
Yeah, there's not too much emphasis on work.
Just the right amount, yeah.
Can you hear us?
Yeah, hi Arjun, how are you?
You.
Did you put the camera that far away purposely to kind of not look bigger than the average doctor?
Is that why you were very close to the screen?
Arjun, there's a few stops as you may have seen in the PowerPoint where hopefully we'll have a few questions from the audience, and if not, I have a few questions kind of set out. I was wondering if you can be kind of the quarterback for your department to direct which staff surgeon would be best to answer which question.
I hope you're listening. Yeah, we can.
Yeah. And also hello. Sorry, I didn't say hello to everyone else. Hi, Arjun's colleagues.
Where's Steven? Is he logging in Valente?
For some reason, my computer asked me to just restart Zoom, so I'll do that quickly.
I don't know. I was just being, I was a neurotic person.
Okay. So when are you guys voting? Is that tomorrow?
Some of us already have.
Because we are 14 hours ahead, so it's the 3rd here. And so some of the Australians are getting confused about, the election.
So you should have the answer for us already.
Can I assume the whole world is tuning into our election?
Well,
Yeah.
I think you'll be surprised how much it has affected the whole world.
Yeah.
Even even the whole mask division. For some reason, our political parties have also adopted the same view. The only difference is our Republican Party is called the Liberals, so it's all kind of upside down.
Just like the globe. Yeah.
We'll just take those and throw them like the resin room.
Oh,
Done.
all right.
If there's, or take it your kids are
They're
It's you know what I mean. Honestly, you're like you want food to eat. You're like a dessert island. I think I get to eat pizza.
Yeah, I agree. My one son likes when I make homemade pizza. It has to have like the perfect amount of tomato sauce, and it can only have like 5 pieces of cheese, right? Like 5 little shreds of cheese. Like that's all. I'm like cheese is so good. This kid's been in therapy.
Hi, I just wanted to check in.
Oh, hi,
Vlad,
Margaret.
how are you? I'm gonna stay on mute and stop my video. Waiting to admit Stephen, and we're on the YouTube live.
Stephen Brandstetter is a guy that Arjun and I did our fellowship with, and irrespective of his colorectal knowledge, his IT knowledge is without question far more advanced than anyone else I know. So he's the resident kind of geek in this whole setup.
Steven can't do it. No one can. About those the Oculus glasses.
Oh yeah.
Oh,
3D.
yeah.
So yeah, he kept them in the colorectal fellow's office, and like he put them on, and like he'd sit in a chair and like whirling around, and then he got Dr. Lee for he used to put them on one day, so I could take a vertigo or something. And now he liked it. It's a good time actually. The microphone's coming down further already. Mask on as a sign of should be good
Oh,
faith.
oh yeah,
No,
probably
either.
because when we record.
Whoever's talking.
All right.
Somehow it's around YouTube Live. I feel like that might be the.
Yeah, maybe we should spread out a little
That's
more.
actually, that's a good point.
Maybe we'll put out.
Like this.
Oh, my
I'll move back here.
Message.
We can swap.
God. Go ahead. Just take a quick Okay.
All right.
Yeah, so that we're not documented as.
Yes, exactly.
Proper protocols are being enforced here.
Probably.
I know. I just hope they can hear us.
When I check.
You're talking.
Now I'm actually closer to the microphone, so it's
Uh, Good evening, everyone. I think it's 7 o'clock Eastern Standard Time. Well, we're going to wait till 7:05 until we start, just to make sure that some of the other people who might be running a little bit late can log in.
Glad they're running a Melbourne Cup program in the United States today, and they're actually showing the Melbourne Cup on TV.
Wow. I was saying earlier, we have a day off for a horse race, and the Melbourne Cup's been running for over 100 years. Unfortunately, I think this is the first year where it's running without any spectators, and it's quite a typically it's a whole week where there are different days, different rules for every day. One day is sort of black and white dress day. One day is women's race. Then Melbourne Cup is the most famous race, although because it's a day off, typically people get more drunk on Melbourne Cup than on any other day. But it usually is a wonderful time of the year in Melbourne.
Mm-hmm.
Yeah, and of course the day off does help.
Mm-hmm.
I think you have the Kentucky Derby or something very similar.
Very, very similar. But there were no people also at the Kentucky Derby this year. So.
يا فالصراحة يعني شعر أعصابي تعبت والله يعني نفسيا تعبت شايفة.
Why do we start? Perhaps.
All right. I think it's time to start. So welcome everybody who's joined us to the DCR Journal Club. Also, hello to anyone who may be viewing this via the YouTube channel. Next slide, please. I'm very grateful for our team, particularly Margaret Abbey and Stephen Brenstetter, who are both subjected to quite frequent emails and demands from me. So thank you very much for putting up with those. Next slide, please. So we ask that the host institution use microphones, and we encourage that the audience comment in the chat bar. We will try to identify the people who have commented and then get them the opportunity to actually ask the questions in our designated breaks. This is a bit different to last time. Right, so Hershey, Pennsylvania is where we are. To quote a famous American philosopher, Homer Simpson, who said, "I've never prayed to a city in my life." And if I did, it'll be Hershey. Hershey is responsible for producing 60 million Hershey kisses every day. And according to Wikipedia, the main road running through the center of Hershey is Chocolate Avenue. And so I personally hope to visit sooner rather than later. Next slide, please. This is the Penn State Medical Center, which looks absolutely amazing, particularly probably now with the colors turning around the trees. Next slide, please. So I'd like to introduce the excellent colorectal department here in Hershey, Pennsylvania. Particular gratitude I'd like to extend to Dr. Jagannathan, who selflessly nominated himself to be the go-to member of the faculty and the local panel of experts. Next slide, please. So this is our first paper that we will discuss. I thank Drs. Cynthia Tom and Jeffrey Scarrow to present this. Cynthia, of course, is the resident, and she will start with summarizing the paper. So over to you. Thank you.
Take my mask off? Okay. Thanks for the opportunity to present at the second virtual journal club on inflammatory bowel disease. The paper that I will be talking about will be biologics and 30-day post-operative complications after abdominal operations for Crohn's disease. Are there differences in the safety profiles? This is a paper out from the Mayo Clinic. Next slide. So up to 60% of Crohn's patients will undergo an abdominal operation after 20 years of disease, and more than 1/3 of these will require another operation within 5 years of their first operation. The literature reports up to 30% post-op morbidity and a 10% intra-abdominal sepsis rate after anastomosis created in these patients. The association between post-op complications and perioperative exposure to biologic therapy remains controversial, with some studies showing worse outcomes, while other studies report there's no effects on the post-op complication rates. This is also complicated by a significant number of confounding variables that are at play. The goal of the current study is to compare the 30-day post-operative infectious complications among 3 classes of biologics, including anti-TNF agents such as infliximab, anti-integrins such as vedolizumab, also known as Entyvio, and anti-interleukins such as ustekinumab. Next slide. Next slide. In terms of the methods of this paper, so this is a single institution retrospective review that was performed between 2014 and 2017 at an IBD referral center. They looked at all Crohn's patients who underwent a major abdominal operation, and they looked at those who had received biologics within 2 weeks of surgery versus a control cohort who are patients that were not exposed to biologics within 12 weeks of an operation. Of those that did receive biologics, they stratified between those that received either an anti-TNF, such as infliximab, adalimumab, or certolizumab, and anti-integrins, such as vedolizumab and ustekinumab. The patients who underwent emergent operations or were lost to follow-up or had surgery in outside hospital were excluded from this study. In terms of the primary outcomes, they looked at 30-day overall post-op infectious complications, as well as intra-abdominal septic complications in those that underwent an anastomosis. The secondary outcomes included 30-day post-op non-surgical infectious complications, superficial surgical site infections, readmission rates, unplanned return to the OR, and mortality rates. Next slide. Next slide. Is there the results slide? Okay, thanks. So in total, we had 712 patients with Crohn's disease that were included in the study. If you can look at this chart here, 272 of those patients received anti-TNF agent, 38 received ustekinumab, and 127 received vedolizumab. And 275 of those patients received no biologic therapy. Overall, between these groups, there was no difference in the corticosteroid use approximately the rate across all the groups was about 25% or a fourth of the patients at concurrent corticosteroid use. So this table that's shown here highlights the differences in the operative characteristics amongst the patients taking different biologics. Can you click, please? Click. Can you click to go to the transition slide? Oh, okay. Don't click that many times. Maybe click once. Or can you go back once? There's like 4 highlights, and go back another one, go back another one. Okay, yeah, they're there. So in this first box, they look at the different procedure types amongst the different biologics. So patients that were taking vedolizumab were more likely to undergo a colectomy with an endoileostomy, and they just found a statistically significant difference in the types of procedures amongst the different classes. Please click again. They then looked at disease phenotype and noted there was a significant, statistically significant difference in the type of disease phenotypes. Patients that were taking vedolizumab were more likely to have perianal Crohn's disease at the time of their operation. Okay, and then the next one, they looked at anastomosis construction. There was no difference in the rate of temporary fecal diversion in the biologics and not biologic patients who were not taking biologics. And then click again. And in the last column, or in the last rows, there was no difference in the rate of sublaparoscopy between the 2 groups. Next slide. So overall, they saw that there was a 19% 30-day post-op infection rate. On multivariate analysis, they found that independent risk factors were taking steroids within 1 month, using an open approach to surgery, patients who were obese, go back. Or can you go back to the prior slide? Okay, well, okay, we'll just continue on with this slide. Okay. So, where was I? Yeah, there's a difference. Procedure type was an independent risk factor of 30-day post-op infection rate and a longer disease duration. Of note, the type of biologic, like whether they took anti-TNF, vedolizumab, or ustekinumab, that was not found to be an independently associated risk factor on univariate or multivariate analysis. So that was not associated with 30-day post-op infections. They also found that there was a 9% rate of surgical site infection. Next slide. And so in the patients who did have an anastomosis constructed, 7% of those, so 31 patients, developed a post-op intra-abdominal sepsis. The risk factors identified on multivariate analysis, and is shown, can you go back a slide? Sorry. Can you go back to the prior slide? Thanks. The risk factors are shown here with the odds ratio associated for patients for risk factors associated with intra-abdominal sepsis. They found that combination immunosuppression with steroids and biologic or an immunomodulator, but not any particular biologic alone, was associated with, okay, I guess the PowerPoint's gone now. But okay, but yeah, so they found that was associated as an independent risk factor with intra-abdominal sepsis. I'll just keep going. And of note, they also found that vedolizumab was associated with an increased rate of intra-abdominal sepsis on